Happened before, sorry. Okay, so I was saying thank you very much for letting me participate in this really interesting webinar. And as Manolo mentioned before, I'm a clinician interested in translational research. So I'm going to focus my talk from the clinical point of view, trying to see where liquid biopsy can help us in the clinical setting. So I'm going to mostly focus in the two components of the liquid biopsy, circulating tumor DNA and circulating tumor cells. And let's see if my presentation moves, because now I have another issue. Okay, this is the outline of my talk. I will briefly mention what is liquid biopsy that I guess that you all are familiar with. And then I will organize everything from the unmet needs in HCC management and see where liquid biopsy can help. So liquid biopsy, what is this? I guess that you are all familiar that liquid biopsy means isolation and analysis of tumor components that are released to body fluids. We mostly associate it with blood samples, but of course it can also be studied in cerebrospinal fluid, pleural effusion, ascites, or whatever. And several components of the tumors can be isolated and also evaluated. As you can see here, the three most extensively studied has been extracellular vesicles that I won't speak about them today, and also circulating tumor DNA that are small fragments of DNA that are released to the fluids, and also circulating tumor cells that are whole tumor cells that are released, in this case, to the blood. Where can liquid biopsy help us? This is the way of an imaginary cancer, whatever it is, and it can help from the very beginning, trying to detect cancer in an early stage by detecting these products on the blood. Also, once that the patient is cured or operated or ablated or whatever, can help us to identify those patients that are at more risk of recurrence. And also we can monitor in a non-invasive manner along the different stages of the disease. And of course, at advanced stage, it could help us to identify patients that are gonna respond or not to different treatments. What is happening in hepatocellular carcinoma? Over the past 3 decades, we have a huge amount of knowledge from a molecular point of view that have been released through different approaches, different platforms, copy number, mRNA, microRNAs, methylome. We have a lot of information that have even built a quite robust hepatocellular carcinoma molecular classification that you can see here displayed in the screen. Which is based on genomic features, immunological features. But when we look at the frame where we move in clinics, which is there are different staging classifications, but the most extensively used is the BCLC that you are probably familiar with. We have 5 different stages of the disease based on liver function, tumor burden, and performance status of the patients, and every one of these stages are linked to an treatment of choice and also a prognostic estimation. But no biomarker is there so far, except for one of the systemic therapies, which is ramucirumab, linked to the presence of alpha-fetoprotein. So where can liquid biopsy help? And I'm displaying here a picture that is mentioning ctDNA, but it could be also applicable to other components of the liquid biopsy. And I like to display it because it's quite graphic. In early stages, of course, we can improve the early detection and also to discriminate those patients that are going to have more risk of recurrence, to be able to be more active with them. And also in the advanced stage, of course, we can differentiate patients with different prognosis. And I think that the most important one probably would be the identification of candidates for particular systemic therapies. So let's go to the unmet needs in HCC management. And I think that the first one is surveillance. We know that HCC is arising in more than 80% of the cases in patients that have chronic liver disease, mostly cirrhosis. And for that, we have screening programs and surveillance programs that are the only tool that we have so far in clinical practice. We use either ultrasound or ultrasound plus alpha-fetoprotein. But as you can see here, and this has been published recently in gastroenterology with a huge amount of patients, the specificity is around 84% and sensitivity is released in this meta-analysis is around 63%. So there is still, of course, room for improvement, but there is still more room for improvement when we look at the implementation, which has been studied and addressed in this meta-analysis, also recently published, in which implementation of these surveillance strategies is around 1/4 of the patients that should be on this surveillance program. So a non-invasive tool would be of interest in clinical practice. There has been several attempts of trying to address this unmet need with liquid biopsy. I'm only going to mention briefly 2 studies, this including mutation profiling of cfDNA in HCC. This is a mix of cfDNA alteration and tumor markers like AFP and also DCP. That has been studied in a cohort of 3,800 HBsAg positive patients that were in surveillance, both with ultrasound and alpha-fetoprotein. And among those patients that had either liver nodules or elevated alpha-fetoprotein, they took the training set with 65 patients that had HCC and 70 that didn't have HCC. Getting a sensitivity, as you can see here, 85% and a specificity of 93%. They took the validation set from the core that didn't have any of those positive alpha-fetoprotein or ultrasound. And as you can see here, they named this tool HCC screen. From those that had the tool positive, 4 of them, which means 17%, developed hepatocellular carcinoma, which of course has a low positive predictive value, but the positive notice is that all the patients were diagnosed at earlier stage. And among them that didn't have the HCC screen positive, I mean, they were negative, they were 300, the same follow-up, no one was diagnosed with HCC. There is another interesting study, here you have the references, that is addressing methylation profiling of cfDNA. This is not the only one, as you will see later, but this is interesting because they have evaluated 10 plasma DNA methylation markers in a cohort of more than 1,000 HCC patients from all stages of the disease, and they have compared with healthy controls, which somehow could have some methodological issues because it's not comparating with cirrhosis, but even though that somehow could be raise this kind of question, the results are quite appealing, having a high sensitivity and a high, as you can see here, also specificity. So they got the FDA breakthrough device designations, and now there is an ongoing prospective trial trying to address whether this methylation tool is good enough compared to ultrasound alone or a combination of both. Here you have the 2 markers that I have mentioned before and another 2 that are currently under investigation and that have regulatory approval from FDA, just for if you are interested in getting more deep in the question. The second topic that I think is important is early stages. We have a patient, we apply a curative treatment, and what happened later? The recurrence, we know that is an issue, so we need to be able to improve prognostication to know which patients are going to have a recurrence, and we need to do a better follow-up of this patient in order to early diagnose a potential recurrence. There are several studies regarding this. I'm showing you one that we developed in our lab regarding cfDNA that has been the most addressed part of the liquid biopsy. We prospectively collected samples from 30 patients that were undergoing curative treatment, 27 of them resection, and we studied the most prevalent mutations in the cfDNA. As you can see here, just the amount of cfDNA was clearly correlated to survival, and also it were the number of mutations and the number of mutations genes that were able to separate, to discriminate two populations with different overall survival and also recurrence, as you can see here. But I think that the most interesting thing, and of course it needs to be validated, is the dynamics, the fact of having a tool that allows us to continuously monitoring what is going on with the cfDNA and the mutations in a particular patient. Here you have or the oldest patient, the first one that participated in the study. He was resected with an HCC, and we follow him for a long time, almost more than 2 years. Here he was treated with the direct antivirals. He was treated again, and then we were able to identify that the number of total mutations was rising almost 1 year before he was diagnosed with a new hepatocellular carcinoma. And here you have also the different mutations, being the third promoter mutations, as it was expected, the most relevant one, and also PP53 and CTNMB1. CTCs have been also studied in this setting, and here is a study from the group of Dr. Agopian in Los Angeles. They compare a cohort of patients, healthy patients and patients at early stage of HCC and more advanced, and they identify and isolate CTCs based on first epithelial markers, CK, and they were able to discriminate patients with HCC from those who didn't have cancer with a good accuracy. But most interestingly, when they added mesenchymal marker as vimentin, as you can see here, vimentin was more positive when the disease was more advanced. This was clearly differentiating patients from early to more advanced stages, and this was also correlated with survival, the fact of having at least one CTC expressing vimentin. In the early stages, patients treated with curative intention also was able to discriminate those that were at more risk of recurrence. So of course, it needs to validate, but interesting results. The same group, a couple of years later, also addressed the issue of evaluating transcriptome profiling in CTCs. They were able to create what they call HCC-CTC risk score, starting from the integrated data analysis of 8 tissue-based gene signatures that have been related to prognosis. They extracted this score with 10 genes, and they were able to examine its expression on CTCs. As you can see here in the whole cohort, it was clearly discriminating patients with high risk and low risk with different survival. But more interestingly, when they look at the same stage, early stages or advanced stages, the score was able to discriminate patients with better or worse prognosis. And what would be the potential impact of detection of this cfDNA or CTCs, meaning potential minimal residual disease? I think that, of course, it needs to be validated, but after a curative treatment, the fact of having detection of what we can call minimal residual disease positive have implications on prognosis. So these patients are at more risk of recurrence. So these are the population that we should select and enrich adjuvant therapy trials on them. And of course, if we don't have the possibility, they need closer surveillance. For patients with MRD negative, of course, it could implicate a better prognosis. Probably they are no candidates to be enrolled on adjuvant therapy trials. and eventually, if demonstrated, they would need less survival and less radiological examination. And just to conclude, advanced stage, I think that is one hot topic so far now, because immunotherapy has completely changed the landscape of treatments for the advanced disease. And we have for many, many years only sorafenib, and the sequence of treatments is very well established after sorafenib, including ramucirumab. That is the only one, as I mentioned before, the only treatment guided by a biomarker. But we have now in front line atezo-bev and also durvalumab that have been superior to sorafenib, and we have been selecting patients for the therapies according to the adverse event profiling. Even with these positive results, we know that only 20% of patients treated with immunotherapy have objective response. So we need to be able to select these patients in order to avoid to the patients that are not going to respond probably the secondary effects coming from immunotherapies or other systemic therapies. In this sense, there has been some papers published. I am going to show you a couple of them. This is an interesting paper coming from Mount Sinai regarding ctDNA mutation profiles and response to tyrosine kinase inhibitors. The investigators examined the mutations of the genes of the PI3K mTOR pathway to elucidate whether if the finding of these mutations in liquid biopsy was able to discriminate different clinical outcomes as it has been described previously on tissue biomarker analysis, and you can see here that they were able to discriminate populations with different progression-free survival. They were aiming to identify also markers in liquid biopsy for immunotherapy, but they were not able to have these findings. However, there have been other reports, and I am showing you one from last year regarding again ctDNA mutation profiles and response to checkpoint inhibitors. This is a multi-center retrospective cohort of 85 patients treated with atezo-bev. The investigators have measured plasma cfDNA levels, and as you can see here, plasma cfDNA levels are correlating with response. Those that have lower amount have more partial response and also complete response, and this is also correlating with survival. And interestingly, the investigator also studied the TER promoter mutations, and also the presence of this is correlated with overall survival. Of course, it needs to be validated. Just to conclude, CTCs has been also studied in this setting. Again, is the group of LA that has been studying the presence of PD-L1 CTCs in order to evaluate if they can discriminate patients responding to immunotherapy. The investigators showed that PD-L1 positive cells were more frequent at advanced stage of the disease, and of course this was correlated with overall survival. But I think that the most interesting thing, even if it's only 10 cases, is that from all the patients that were expressing PD-L1 on CTCs, 5 out of 6 respond to immunotherapy. 1 had to change to another therapy, but all the patients, 4 that didn't have PD-L1 expressing on CTCs, didn't respond to immune checkpoints inhibitors. So again, a proof of principles that need to be validated, but interesting results anyway. So yeah, to conclude, HCC has poor prognosis, mainly related to diagnosis at more advanced stage, high risk of recurrence, and resistant to therapies. I think that there is a potential role for cfDNA and CTCs in these settings. There are already 4 biomarkers based on cfDNA that had the breakthrough device designation for surveillance. cfDNA and CTCs have significant potential also in detection of minimal residual disease, and so in prediction of recurrence and prediction of response to systemic treatment. And last but not least, and I think is the most important message, is that technology is evolving and results are promising, but we need more research to standardize the procedures, to reduce the operator variability and to minimize false negative results. And this have to be organized by a complete definition of methods of detection, quantification and characterizing of cfDNA and CTCs. And we need to homogenize as well the study design, patient selection and outcome reporting, followed by validation of these biomarkers in phase 3 trials that is necessary before implementation into clinical practice. And with this, thank you very much for your attention.